Hey guys, welcome back to my channel. This is the second installment of the revision questions for West African College of Surgeons primaries I started. After this installment, I'm going to do a devoted session for pathology, maybe 1 or 2 videos. If this is your first time visiting my channel, just do me a solid and subscribe. And for the returning viewers, thanks for watching my videos. I hope you find them useful. So let's get right to it. If you have not also watched the part 1 of this revision questions, I'll provide a link. You just look up, you see a link through which you can watch the part 1, and then this is a continuation, so we dive in. In question number 26, we stopped at 25 initially. In a normal young man, what is the maximum pressure that can be achieved within the corpora cavernosa during sexual experience? Okay, I think I hinted on this question. It came out in my own exam and in so many other exams previously, and it's always a source of laughter. But I think it's an important question, and to answer it is also easy if you're remembering that what is causing penile erection is actually blood flow. And blood flow is increased with increased stroke volume, which should increase blood pressure ordinarily. So it's arterial blood that we're talking about that goes there. Of course, congestion and restriction of a venous return is what eventually is the turgidity. But the whole point is that you're looking at systemic systolic pressure. That's what you're looking at. So usually the maximum pressure you can generate in a safe, not enhanced now, safe situation, circumstance, you're looking at the upper limit of the systolic blood pressure, and the only close or sensible answer we can see here will be option C. Yes, option C. So that's our answer. Okay, so we move. Question number 27. Which of the following neurotransmitters at the nerve ending of preganglionic neurons stimulate adrenal medulla? This question has also been answered in part 1, if I remember, or by a related question, which is that preganglionic neurons in the autonomic system release acetylcholine. It is in the postganglionic system that you start having variations, so we still go with this acetylcholine. Alright, so these are easier questions, so I won't spend time on them. I tried to give background knowledge on questions that require them. So this is a phenylethanolamine N-methyltransferase, catalyzes the production of the following: say epinephrine, norepinephrine, and dopamine. So to be able to remember this answer, the answer is epinephrine, but to be able to remember, I want to show you a pathway, the synthesis pathway for catecholamines, that is noradrenaline and adrenaline. So you also remember, because the question can come in the fashion of which amino acid is the root source of this catecholamines. So let me get you a picture. Yeah, so this pathway of catecholamine biosynthesis, so you see that it starts with yes, I hope you can see that. So it starts with phenylalanine here, all right, that is converted to tyrosine by phenylalanine hydroxylase. So tyrosine is converted to dopa by tyrosine hydroxylase, then a dopa decarboxylase converts it to dopamine. So it can be, the question can be asking which amino acid, or can be asking about a precursor of say adrenaline that can stimulate the receptor at low dose, and that will be dopamine. And then you also have noradrenaline before epinephrine or adrenaline, and this is the enzyme we'll be asked about: phenylethanolamine N-methyltransferase, PNMT. I think I'll stick with the abbreviation. So this is the enzyme that catalyzes the production of epinephrine, which is like the final pathway in the biosynthesis of catecholamine. Alright, so that is our answer there. If you're talking about the degradation, you have to talk about the enzyme, but that's not what we're talking about here. So 29 is allograft. Allograft, different organism of same species. Of course, I think this is a simple question, but I would just like to list that. Allograft, yes, different organisms of same species, like one human giving another human a donation, skin graft or whatever. No, which one is popular? People talk about kidney, yeah, kidney, or even organ donation generally, whether it is a heart or a piece of the liver. That is an allograft. Then different organisms or different species would be a xenograft. From twins, if they are identical, you're looking at an isograft. And then if it is one person having donating to himself or herself. That is from one part of your body to another. You see an autograft. So this is also an easy question, and we move. Which of the following event does not occur during the process of mitosis? Okay, to answer this question, you need to understand the cell cycle. I think if you understand that, it will be easy. So we'll read through this, and then if you remember the cell cycle, the G1, S, G2, and M, then G0 is outside. So if you remember that, you're asking yourself which one does not happen in M. So you have condensation of the chromosome. Okay, that's supposed to be what should start mitosis or mitotic phase. Replication of the genome. So this is like synthesis of the DNA. So you realize that this is more like what should happen in synthesis phase, which is the S phase of the cell cycle. And that should obviously be our answer. The rest should actually happen in mitosis. Fragmentation of the nuclear envelope, alignment of the chromatid along the equatorial plate, separation of the chromatid into two daughter chromosomes. So I'm going to show you quickly just a picture of the cell cycle in case you have not imagined it. So this is it. G1, cell growth, DNA replication. That is where you synthesize or replicate the genome. Then there's this preparatory phase for mitosis before the cell division properly occurs, after which cells can go into a resting phase, a terminally differentiated phase, or can re-enter the cell cycle and just continue dividing. Alright, so that is that for that question. So our answer is replication of genome. Question number 31. Weightlifting can result in a dramatic increase in skeletal muscle mass. This increase in muscle mass is primarily attributable to which of the following? For muscle mass increase, usually you either, or for an organ, a tissue to increase, you either have hypertrophy or hyperplasia. For muscle, especially if what you're exerting is force, you're expecting hypertrophy. So we're looking for that. It's one good way to actually answer exam question, which is know your answer and then look for your answer in the options. So fusion of sarcomeres with myofibrils is not our answer. Hypertrophy of individual muscle fibers should be our answer, but let's finish the options. Increase in skeletal muscle blood flow. That happens during exercise, but that's not what is primarily responsible for the increase in size. Increase in number of motor neuron. No. Increase in the number of neuromuscular junctions. No. So we are left with our option number B, which is the correct answer. 32. A plastic surgeon took the inferior rectus muscle with its vascular supply, engrafting the site on mastectomy with vascular reconstruction done to preserve its blood supply. Which vessel is being transplanted with the muscle? Okay, I'll try to do a little explanation here. What you need to understand to answer this question is what we call TRAM and DIEP or DIEP. Okay, so these are two ways, two related ways actually of a reconstruction after mastectomy, and they all involve the same vessel and the same region, which is the lower abdomen, lower anterior abdomen. So TRAM is a transverse rectus abdominis myocutaneous flap, and the DIEP is a deep inferior epigastric perforator flap. Both of them involve the same vessel, which is the inferior epigastric artery. Rectus abdominis, the major blood supply comes from inferior epigastric and superior epigastric, but the inferior epigastric is the major one. Okay, and you can take a piece of the muscle together with its blood supply. That I call a flap. It can be pedicled or not. So together with its blood supply, you use to reconstruct a mastectomy site. That will be TRAM. But sometimes the dissection is done in such a way that what you're taking out is the deep perforating branches of the inferior epigastric artery together with soft tissues, not muscles, and that will be the DIEP. That's what I call it, DIEP. So I don't think currently there is so much difference in outcome to cause one to recommend one, but then I don't think that's also important knowledge in the exam. But you need to know this just for knowledge sake, and then of course that will help you know that it's the inferior epigastric artery that is the answer here. So we'll highlight that. All right. Question 33. Secondary active transport in the proximal tubule is used in the transportation of the following. I think this is easy too, so I won't waste time on it. So glucose, if you're absorbing ions like sodium, it can be transported with glucose. That's your secondary active transport. One is being absorbed actively and the energy generated is used to absorb the other. That is what happens in the proximal tubule. Okay, so this question number 34 is a bit dicey even though it looks simple. So what I will do is I will explain what should guide you in making answer choices in any exam that involves MHCs. Okay, major histocompatibility type 2 is expressed on the surface of. So the question is expressed on the surface of, not recognized. MHC1 type 1 is expressed on unnucleated cells. So that's except a red blood cell, mature red blood cell, for example. And then MHC2 are expressed mainly on antigen presenting cells. Okay, but cells carrying MHC1 can still present antigen. And what you observe is these two, that's option A and option B, for example. Option A and B are all going to be able to recognize antigens. Antigens are presented to them. Macrophage is an antigen presenting cell, which is what I would choose in this question anyway. But then this is why it is tricky. Why it is tricky is that, of course, these two cells, A and B, are nucleated. But then the antigen they recognize vary in terms of the MHC that the antigen presenting cells carry. The cytotoxic T cell, which carries the co-receptor CD8, so call it CD8 cells, okay, they recognize antigens presented on MHC1, okay, but helper T cells recognize antigens presented on MHC2, and their own co-receptors for the MHC is CD4, so call them CD4 cells. So you look at that, sometimes you may be tempted to say, okay, CD8 carries MHC1 and CD4 carries MHC2. But then if that is what you think, answering this question might now be difficult. So I'm explaining this and I'm choosing macrophage myself. But then on the exam condition, if you understand the basic concept, you should be able to make your own decision. Alright, in case you don't agree with me. 35. Mediate primary immune response but too large to cross the placenta. Okay, so this is also an easy question, so I won't waste time on it. We all know that when you have immunoglobulin G, it crosses the placenta, and that's when you can have things like erythroblastosis fetalis or hydros fetalis. But immunoglobulin M, which should be the largest of the immunoglobulin, does not cross the placenta, yet it is the first or the antibody that is actually secreted to mediate primary immune response. So that is immunoglobulin G or mu. Immunoglobulin mu or M, sorry. Question number 36. Can increase bleeding time except. Okay, so bleeding time is increased or deranged by anything that affects the number of platelets or the vascular integrity, because what basically makes bleeding stop or affects bleeding time is that if you injure a vessel, the initial thing is, of course, the vessel wall contracts and there's platelet plug, and that what stops the bleeding. So if there's a problem with platelet or a problem with the vascular integrity, you have increased or prolonged bleeding time. Vitamin C deficiency, hydroxyproline, and all those things that happens to collagen will not happen. So the cross-linking will be poor, and that means there will be vascular problem, which should be why you have scurvy, bleeding from the gums and all. Malignancy, depending on the malignancy, it can infiltrate the bone marrow, for example, and then you have a low platelet. So that's a possibility. Hemophilia happens in deficiency of factor 8 or factor 9. Von Willebrand disease will affect von Willebrand factor. So if you're looking at it, clotting factor deficiency is not supposed to be prolonged bleeding time. It can cause other derangement in PT and the other clotting profile parameters, but then not really bleeding time. Von Willebrand disease can prolong bleeding time, I think, yeah. So thrombocytopenia, I've already explained that aspirin is an antiplatelet, so you will expect the same result. So from this option, the more sensible answer would be hemophilia. if we are assuming that malignancy can invade the bone marrow. Question 37. This is pretty long stem, but I have a longer stem question because I wanted to show you something. So when we get there, I will remember to mention. A woman whose blood type is A positive and who has always been healthy just delivered her second son. Okay, the father's blood type is O negative because the child's blood group is O negative. What would you expect to find in this child? Now, they are telling us the second son because they want to create a picture in our mind, and that picture is that for you to have erythroblastosis fetalis, usually it is in the second pregnancy after an initial sensitization, but you have to know that this thing occurs in O negative mothers who are having a positive in a rhesus negative mothers who are having a rhesus positive child. Okay, so this mother is rhesus positive already. There is no sensitization to be done, and this child, the father's blood group is O negative and the child is O negative, so no sensitization is to happen, and this child is not at risk of erythroblastosis fetalis. So we'll just look for that answer. Erythroblastosis fetalis due to race recoverability, no. Due to ABA incompatibility, no. The child will not be expected to have HDN, which should be my answer. Okay, the child will not be expected to have hereditary disease of the newborn. Okay, so hydrophytalis should not happen. Question number 38. What is used in quiet respiration? When you're quietly respiring, the only muscle that should be active, of course, is the diaphragm. But then, if there is respiration with effort to exertion, you start recruiting the other muscles of respiration like the skeletal, internal and external intercostal, and even abdominal muscle for forceful respiration. So that's our diaphragm there. Diaphragm only. That will be the answer. Question number 39. Chemotactic agent derived from arachidonic acid. Okay, so this is a very specific question because there are chemotactic agents that are not from arachidonic acid. Arachidonic acid is source of prostaglandins and leukotrienes via the different pathways, okay? Lipoxygenase and cyclooxygenase pathway. So C5A and C3A are chemotactic agents, but they are derived from complement activation. Leukotriene B4 is chemotactic and is of course derived from arachidonic acid, which is our answer. Prostaglandin E derived from arachidonic acid is not chemotactic, so that is not the answer at all. Question number 40. During development, the arytenoid cartilages arise from which of the following? Okay, so the laryngeal cartilages arise from the fourth and the sixth. Fourth and the sixth. Okay, I should write that down. Okay, so fourth and sixth pharyngeal arches. But then the arytenoid arises from the sixth. The rest can safely answer fourth and you'll be correct. And even in these options, if the options comes like this in exam, it is safe to make a good guess because there is no fourth. So of course that leaves us with sixth. So but just know that the laryngeal cartilage arise from the fourth and the sixth pharyngeal arch. And if they're saying arytenoid specifically, we're taking sixth. Alright. Question 41. In the brain, the amygdala plays an important role in emotional processing. Patients with lesions of the amygdala display impairment in enhanced perception of emotional silent event. Which of the following is a major output pathway from the amygdala? Okay, so what I was going to say in a long stem question, I've not gone to the long stem, but I'll say it here is, if you have a long stem question, try and read the last sentence first before going to start from the beginning. They don't give long stem questions in West African College of Surgeons exam again for now. I don't know, they can change their mind. So, but should you ever meet long-term question in any exam, it's always important to read the last sentence, because it can give you complete information. And if it doesn't, you can go ahead and read it. If it gives an information that requires, lets you know that you need to read the stem properly, you go back to reading the stem. So let me answer this question. The question here is, which of the following is a major output pathway from the amygdala? Okay, fasciculus arcuatus, or the arcuate fasciculus, is not our answer, because arcuate fasciculus connects the Broca area with the Wernicke area. This is the arcuate fasciculus. So that's definitely not our answer. Fasciculus cuneatus is a part of the dorsal column lemniscal pathway. So that's also not our answer. Dorsal column. Okay. The output of amygdala is what we're looking for. Fasciculus ovidaza, I hope that's pronunciation, is also called mammalothalamic tract. So definitely not our answer. Thalamic, yeah. Mammalothalamic tract, definitely not our answer. The phonics is the output of the hippocampus. Okay, so that leaves us with stria terminalis. Of course, you have to choose that, or you say there's no answer in the option. So this is our answer, the major output of the amygdala. Okay, question 42. So this is where I was going to talk about answering long-stemmed question. This stem is so long that it is annoying. Okay, but then if you read the whole stem, you might get to the end and realize that you'll be more annoyed, because you are seeing that none of that was necessary. An infant is both anencephalic. Is born anencephalic. An infant is born anencephalic. He presents without both a forebrain and a cerebrum. The remaining brain tissue is exposed, not covered by bone or skin. The infant is blind, deaf, unconscious, and unable to feel pain. Because the infant has a rudimentary brainstem, reflex actions such as respiration and response to sound or touch occur because the brainstems are fairly developed. However, the lack of a functioning cerebrum permanently rules out the possibility of ever gaining consciousness. Now look at the question and then tell me whether you needed to read all the stem. Anencephaly is the result of a defect in which of the following? If this comes as the question, it is a complete question. So the whole stem was unnecessary, but then they are trying to sound clinical. So anencephaly is the result of a defect in which of the following? If you remember your neural tube, so this is more like neural tube defect questions. So you have a neural tube folding, and then you have the rostral, or the cephalic end, which should close earlier than the caudal end of the neural tube. The ends are the neuropores. Okay, failure of closure of the cephalic or the rostral neuropore is what will lead to anencephaly. It's not compatible with life. And then failure of closure of the caudal, which will be giving you various kind of spina bifida. Okay, so the answer here would be closure of the rostral neuropore. Anencephaly is defect in which of the following? Defect in closure of the rostral neuropore. And this rostral neuropore is supposed to close around 24-25. Okay, 24-25th day. Okay, whereas the caudal neuropore ought to be closing 27-28th day. Alright, so that's neural tube defects question and an unnecessarily long stem. Question number 43. An elderly resident of a nursing home fell down. This is likely the same as the above. Fell down from the front steps and subsequently became disoriented and lethargic. He is brought to the emergency room, where an emergency MRI reveals that he has developed hydrocephalus due to a small hemorrhage obstructing the foramen of Monro. The foramina of Monro allow for communication between which of the following? Reading the last sentence could also have given away the question. So if you remember your ventricular system, okay Alright, so these are the lateral ventricles. So these are your lateral ventricles. This is the third, and this is the fourth ventricle. Okay, so these are the interventricular foramen of Monro. This here, interventricular foramen of Monro. So of course they are connecting the lateral ventricles. They are connecting the lateral ventricles to the third ventricle, which one we'll be looking for. The third ventricle is connected to the fourth ventricle by the cerebral aqueduct of Sylvius, and it is from the fourth ventricle that in the midline there is a foramen of Magende that should drain into the subarachnoid system, and then laterally you have the lateral foramen of Loschka. So I don't know if I need to write those, but let me still do. So here you are having media, M for media. Okay, so media is foramen of Magende. Hope that's the spell pronunciation here. And then you're having a lateral, L for Loschka. So foramen of Loschka. There should be a H here. So those are the two foramina you're expecting. Okay. Yeah, right. Take it up. Yes. So foramen of Magende, foramen of Loschka. Those are the two foraminas. But if you're looking for the foramen of Monro, they are between the third and the lateral ventricles. All right. A lot of time wasted. So our answer should be lateral ventricles and the third ventricles. Option C. Question number 44. Which of the following dural venous sinuses is associated with the falx cerebri? So this is also a simple question, and I'll just show you a diagram from Teach Me Anatomy site. Okay, so this is the dural venous sinuses. Okay, and what you can see here is, all right, so you can see the most superior venous sinus here, which is the superior sagittal sinus, and then the superior sagittal sinus, okay, taking a little time to come up. Yes, so the superior sagittal sinus will end down posteriorly at this confluence of sinuses, and then you see the straight sinus coming to drain into it, but the straight sinus is formed by the inferior sagittal sinus labeled under the superior sagittal sinus, and then the great cerebral vein of Galen. You're looking at that, which is supposed to drain into the, supposed to be, yes, drain into the inferior sagittal sinus. Together they form the straight sinus. So these two form the straight sinus, and of course there's the transverse sinus to taking off from the confluence of sinus that will continue at the sigmoid sinus. Well, the point is that if you're looking between the superior sagittal sinus and the inferior sagittal sinus, you will see what looks like a drape, and that is the falx cerebri. So if you have this picture in your head, you should be able to remember the answer to that question. All right, so we will highlight the superior sagittal sinus as the association of the falx cerebri. Question number 45. Premature female infant is born about 24 weeks after fertilization and develops rapid labored breathing shortly after birth. She is immediately transferred to intensive care, where she is diagnosed with hyaline membrane disease. Which of the following is most likely deficient in this infant? So this is a case of lack of surfactant, which is produced by the type 2 pneumocytes, of course, or type 2 alveolar cells. But it's not like the type 2 pneumocytes are absent. It is that they are not mature enough to produce enough surfactant. So you have lack of surfactant causing respiratory distress in this baby. So alveolar duct is not deficient, lung surfactant is deficient, terminal circles are not deficient, and the pneumocytes are not deficient per se. Type 1 pneumocytes are the main respiratory cells anyway. Question number 46. Which of the following is characterized by an absence of lymphoid follicles and germinal centers? Lymphoid follicles or germinal centers are seen in secondary lymphoid organs, and all the organs listed here basically have the same microstructure, the same histology, apart from the thymus. Okay, So all of this, yeah, they are like, the spleen is like a large lymph node. So the largest lymph node in the body, so to speak. It's not a lymph node, but structurally they are similar, okay? And this is where B cells mature, the germinal centers. But the thymus does not have that. The thymus has more of a reticular kind of microstructure. And then in the innermost part, you have what they call Hassel corpuscles. Let's see if I can just write that. So Hassel corpuscles, so they're like walls of epithelial cells. Okay, so this is the only organ with a different histology from the rest here, and that is our answer. So we move on. Question number 47. The abdominal aorta provides for the major blood supply in this region, and these branches are organized into paired and unpaired visceral or parietal branches. Which of the following are paired visceral branch of the abdominal aorta? They already gave a clue here that they are paired parietal branches and they are paired visceral branches, so that you don't confuse them. So the ciliary trunk is an unpaired and an anterior visceral branch, okay? Gonadal arteries is paired and is visceral. Inferior phrenic arteries are paired but somatic or parietal. Lumbar arteries paired but they are parietal. Superior mesenteric unpaired anterior visceral still. So that leaves us with the gonadal arteries as the answer. During surgical resection of the gastrointestinal tract for treatment of long-standing irritable bowel syndrome, a surgery resident is asked to select a surgical site coinciding with the termination of the vagal innervation. Which of the following does she select? So this is a question trying to test your knowledge of autonomic innervation, parasympathetic non-autonomic innervation of the GI tract. The vagus is supposed to cover both the foregut and the midgut. Then the pelvic splanchnic will take over the remaining part of the gut. So we're looking for what is closest to the division between the midgut and the hindgut. The duodenal junction is not it, because that is still part of the foregut, okay, and the midgut region. Ileocolic junction also still in that region. Junction of the second part and third part of the duodenum still in that region. Then the left colic splenic flexion and the right colic splenic flexion. Okay, so speaking anatomically, the junction between the midgut and the hindgut is more accurately somewhere between the first divide the transverse colon, yes, divide the transverse colon into three. So 2/3 proximal is still midgut, and then 1/3 distal is non-hindgut. So if we're taking that as our division, you will realize that the closest answer here will be the left colic or the splenic flexure. Okay, so that will be my answer. Question number 49. I'm glad I'm at 49. I don't like making long videos, but when you're making review questions and answers with a few explanations added, you can't help it. So that's why I'm rushing. So which of the following thalamic nuclei observes a motor function? Okay, so the thalamic nuclei are many, and the anatomy is, of course, just like everything in neuroanatomy, so a bit to chew, but then I'll pick the answer. Some here are very obvious, like the lateral geniculate nucleus or medial geniculate nucleus. We already know they are very sensitive because they are they subserve functions, visual and hearing function. The lateral for visual and the medial for auditory function. So the ventral lateral nucleus is our answer here. You can look up on the anatomy of the thalamus if you are so interested, but I think they rarely ask details of neuroanatomy, okay? So I won't also go into details of it. So we are at the end of it, and this is the sensory innervation of the posterior 1/3 of the tongue is performed by cranial nerve 9, that is glossopharyngeal. During development, this region of the tongue develops from which of the following pharyngeal arches? Okay, so the pharyngeal arches, I will just list them and the nerve only. Okay, so the first arch Nerve of the first arch is trigeminal, that is 5, cranial nerve 5. Nerve of the second arch is facial, that's cranial nerve 7. Okay, then nerve of the third arch is glossopharyngeal, that's cranial nerve 9. Then nerve of the fourth arch is vagus, okay, that's cranial nerve 10. And nerve of the sixth arch is also still vagus. So fourth will be superior, and then sixth will be recurrent laryngeal, okay, and both of them are branches of the vagus. So if we follow this, that means our answer is quite obvious, and that is the third pharyngeal arch. Okay, so this is the end of the second installment of this video. I'm hoping it's not too long and boring, my next video will likely be on pathology. I just want to do a focused review of pathology questions, so that once you finish watching them, you know you have done a revision on pathology after you have done thorough reading, of course. So remember what I said as I shared my experience on the exam, that reading is more important actually than doing all these revision questions. But the revision questions are important because they will also help you to know how far you have gone and whether you need improvement. So it's important that maybe midway in your reading you start doing revision questions, so that you do not start doing them too close to the exam and get destabilized because you realize you are not so prepared. But it's actually brilliant if you come to the revision question and realize that you know almost everything already. It doesn't mean they are useless. It just means that, oh, it's a nod that you're preparing and your preparation is paying off. So thank you guys for watching my video. If you have not subscribed, I would like you to subscribe to my channel, as I'll be making more subsequent videos. And if this video is helpful to you, it will be brilliant if you can give it a thumbs up and possibly comment. Thank you and good luck.